refuse to subject myself and my family to purposeless, prolonged pain and suffering at the hands of an incurable disease.
Good evening. We join together tonight on an issue of great public import, one that has been discussed at family dinner tables, litigated in courts, and debated in legislatures, one that has seen tears from many of those involved. This evening, we are here to listen to others who may feel differently from ourselves and to have an open exchange of ideas. The expectation isn't necessarily to reach a conclusion or even consensus, but to get at the nuances on the issues and perhaps understand varied perspectives a little better, being mindful to respect our differences, willing to hear the opinions of others, and open to learning something new. Honest disagreement is often a good sign of progress, Gandhi said. Thank you all for your attendance and your civility. Mr. Simon, the first question is to you. Is there any right more fundamental than that of a person to live or die?
I don't think so. I think the right to privacy, that the control by which you control your ability to live and control not dying. Dying is beyond, most often beyond our control. It's the circumstances, the timing, and the manner of our death that I think is fundamental. And that's what I and our organization, the American Civil Liberties Union, have fought to protect. By coincidence, I have fought on that issue both in Florida and the state that I came from 21 years ago, in Michigan, where this issue was, people may recall, was rather prominent in Michigan with Dr. Jack Kowalski, and we had lawsuits on behalf of doctors and terminally ill patients. At the same time, Dr. Kowalski was in court defending himself as well. When I moved to Florida 21 years ago, by sheer coincidence, we were involved in a lawsuit before the Florida Supreme Court on behalf of doctors and terminally ill AIDS patients. And on the issue, we have all the video talking about all these different terms. The term, and maybe what term you choose is also an indication of how you look at it. But the term we use, and what was the issue then before the Florida Supreme Court, was do terminally ill patients, and then that's a term of art and has to be defined. We get into that, what that means at a later date. Do they have a right to have their doctors prescribe lethal medication, which they can take, not that will be administered to them, although we should get in and discuss that issue as well. But do they have a right to have their doctors prescribe lethal medication that they can take in the end stages of their life when treatment has been exhausted and they are within 6 months of death? That was the issue before the Florida Supreme Court. And it's the issue. The video is a little bit inaccurate. It listed 5 states. There are now 6 states in the country in which terminally ill patients do have that right.
Dr. Gillis, to follow up on Mr. Simon's point, do you believe that terminally ill patients have the right to have their doctors prescribe lethal meds when all treatment has been exhausted?
So, green. Okay, thank you. I'm a philosopher by training, and philosophers by training are very annoying, and we're not going to give you a straight up answer on anything. The kinds of things that concern philosophers, like we don't have individuals have political points of view. The concern with philosophers is to try to understand the concepts that are being discussed when we talk about these things that we've already brought out. There's a lot of different terms. And what kinds of things are actually at issue. So I think that one of the things that's already come up, and if you want to start to see how annoying a philosopher can be, I'll ask, again, we're seeming to talk about a lot of different things at the same time. And one of the things that I'd like to talk, does everybody know the difference between the states that we've talked about and what the acts are that are legal there, and the Kevorkian case, and what's similar and what's different about those two things? Because they're very different.
I'm sure we're not.
Please, because they're very different things. Because what we're talking about in the States was when a terminally ill patient, and that's a patient who only has 6 months or less, they've been diagnosed as having 6 months or less to live, okay? And the next important thing is that they have something called capacity. And capacity is the ability to be able to make decisions for oneself. Okay, it's not talking about somebody who's already unconscious. It's not talking about somebody who either throughout their life or later on can no longer make decisions for themselves. So we're already talking about a pretty small class of people. They are prescribed a lethal dose of a drug to terminate their own life. But the case in Michigan with Kevorkian was when the doctor's hand itself was that brought about the death of the patient. So it's, we can talk about different kinds of things, but that's a huge issue because, and we can get into the nuances of why Kevorkian actually finally did what he did, because the patient had ALS and could no longer do it for himself because it left too long, so the patient would have taken his own life, but he couldn't. But they're very different things. So the question becomes, like philosophically, is this the same thing as suicide? Right? And that's what a lot of religious people who have religious bents are concerned, and non-religious as well. You don't have to be religious to have problems with the idea, the ethics of suicide. So one of the things that we say is this exactly the same thing as suicide, or is because the patient is dying anyway, and because the patient has the capacity to make their own decisions, does that make it a different kind of case?
Dr. Gillis, if the person in Florida has the capacity, if they have 6 or less months to live, if they're able to make the pronouncement both in writing and orally, is legislation in Florida something that you would support as a medical ethicist?
Again, I'm very annoying. I'm not going to give you an answer to that. I'll bring out my concerns, like in the things that I think that we have to talk about before we give a yay or a nay on that. And so a person with capacity being able to make decisions for themselves. One of the things that everybody can do as a patient is give their informed consent, and we should be giving our informed consent for any medical procedure. And the ethical underpinnings of informed consent are the right to respect what we call patient autonomy. And autonomy is something that human being, it means self-determination. It means that human beings can, once we reach the age of majority, and if we have capacity, can make decisions for ourselves to live our lives the way we want. And that's what you mentioned at the very beginning when you talked about a right to life. You talked about the right to pursue a life the way you wanted. Now, if we have those things, We also have at the same time, like when you consent, like I say this to medical students all the time, it's about informed choice. It's really not informed consent. When we say to a patient, here's what we'd like, here's the situation, here's the diagnosis, here is the evidence-based treatment that we'd like to go with, and we don't see any good alternatives, this is what we'd like to go forward with. And a patient, if they understand it, you can ask them questions, you can see if the patient understands what's going on, but the patient has a right to refuse the treatment. Right? That's what we mean when we talk about respecting patient autonomy. It just doesn't mean that I've talked to you and you agree with everything that I want to do with you as a physician. I'm not, but suppose I were, right? And just by the way, it's really interesting that physicians usually don't judge or they don't worry about the capacity of patients unless they disagree with them. But it's true, it's absolutely true. But the whole point, and it's a really robust concept, that when we talk about respecting patient autonomy, yes, it means operationally that we have to get informed consent for procedures, but it also means the patient has a right to refuse, right? So when you start to talk about things like, I would like to put on the table whether or not when we talk about wanting to die, and remember I said that we have to look at this as, is this a kind of suicide, right? It's perfectly legal for a patient who has capacity, who has not been judged as depressed, which, getting a terminal illness diagnosis is usually not, it's a trigger. Whether or not refusing food or refusing water, which is legal and will hasten your death, is the same thing. And if we allow one, and we think, because we think that this one is ethically okay, then why don't we allow the other?
Mr. Sondland, if we could get back to you, what impact could right to die laws have upon the private business community? Could you discuss your thoughts on a private business having to pay for, or a religious hospital having to provide a procedure it is morally opposed to?
Sure, I'm not sure I understand the first part of the question, but I certainly understand the second part of the question about religiously affiliated hospitals. I'm not sure about the first part, but Judge Paul, can I take a second to respond a little bit here? Because we didn't have a chance, we never met before, we didn't have a chance to talk about this. So I want to make a couple of things clear. I have not now, nor have I ever been a lawyer. Judge Paul is the lawyer. I am, by coincidence, a philosopher. I have a PhD in philosophy, and before 44 years of a career with the American Civil Liberties Union, I taught philosophy at 2 different universities in the Midwest in the United States. So I went from teaching philosophy to working for the ACLU because I wanted to advance and defend values. So I will be maybe not annoying like a philosopher, but I want to put something out on the table about, in answer to the question about whether we should have these laws. I think your question was, should the legislature enact laws? I have to say, I think the legislature should enact the law. I don't think the legislature should, because I think it is so fundamental as a constitutional right. It needs to be recognized as a constitutional right, not a law that can be passed by the legislature, which they can amend and repeal next year or the year after. So I do want to say, and putting it out there and try to elicit some conversation about this, my God, I think this is the middle of a revolutionary moral and intellectual process that we are involved in this country. When 6 states have done it, when it is, as you have said correctly, it is clear, it is not controversial anymore. It is clear, I think, since the United States Supreme Court ruled, I think in 1990, that a person, a competent adult, has the right to refuse medical treatment, and they have a right to refuse medical treatment even if that means that it hastens death. That is nailed down. What is not nailed down is, while I have a right to refuse treatment and hasten my death, I don't have a constitutional right in all but 6 states in the United States to have a doctor prescribe medication that will hasten my death in the end stages of a terminal illness. So I want to say, as clear as I can, I'm an advocate against that. I think that needs to be changed. I think we need to recognize that right. I think the practical, I want you to think about what the practical consequences are of not having that right. And of course, I see the practical consequences of not having that right, and I know and I hope and I presume people will disagree because the video talked about two different points of view. Not having that right, in my view, is medieval and barbaric. It says to people that, I'm sorry, but you're just going to have to endure pain and suffering in the last few weeks of your life. And I just don't think that that's the way an enlightened society should live. Now, let me go back to your question. I'm going to, if you don't mind, skip the first one because I don't understand.
Okay.
The impact on business. But I certainly understand the impact on religious hospitals, and I want to say I lost track of the percentage, but I think maybe more than half the hospitals in this country are Catholic-related hospitals. And Catholic-related hospitals operate under the protocols, as they're not called protocols, what are they called, of the Catholic bishops. They are the edicts, protocols, or the directives, I think they're called directives of the Catholic bishops, which means that there are certain procedures that they will not perform. Obviously, they will not perform abortions. They may not perform many of them tubal ligations. And this is what you raise is a very interesting issue. And you're the lawyer, you're the judge, so I want to ask you the question about this. Because,
I should have started this program with telling you I'm not allowed to have opinions on this issue.
But here's the problem for Catholic-related hospitals. A person shows up with an advance directive, and the advance directive might be do not resuscitate, or it might be I do not want to be sustained by extraordinary artificial measures. And the person has a catastrophic automobile accident, and because most hospitals in this country now are Catholic-related hospitals, they get delivered there. What does that hospital do? I don't think I guess what happens is, and I'm no expert on the administration of Catholic hospitals, but I presume what that means, maybe Henry help me out here, I guess what that presumes is that they get transferred somewhere else.
Well, generally speaking, the directives make a distinction between passive and active, right? So the withholding of treatment is perfectly permissible and not in any way problematic. Active prescription or active termination of life on the part of the medical professional is a violation of
And so
medical
is
directives.
withdrawing care too in Catholic hospitals, because withdrawing care is considered passive.
Withdrawing care, such as removal of feeding tube, is considered an active form.
Well, I thought that letting go was a passive form because it was allowing natural death.
No, it's because sustenance, both with respect to food, but also the ability to breathe, is so fundamental or constitutive of life itself. The impeding of that or the hastening of that by removing it is an active mode of euthanasia, and thus not, ethically permissible.
So let's get it out on the table, because there are two big words hanging over this event here, which is another major lawsuit that we were involved in, probably the most bitter and contentious lawsuit that the ACLU was ever involved in for a period of 6 years, and those two words hanging over, which is what Dr. Mack is alluding to, is the Terry Schiavo case, because that's exactly what happened about the issue about the withdrawal of nutrition and hydration that hastened death, and there was a big battle when the then Governor Jim Bush got authorization from the legislature and from Congress to intervene in the case and prevent the withdrawal of nutrition and hydration. And we fought that as an intrusion into 6 years of litigation between a family, but we can get into that. But that is a key distinction that we have to make in this conversation, the difference between active and passive. So anyway, I don't know, but so I guess your question was the impact on
Religious
on
institutions.
religious institutions. I presume religious institutions have a First Amendment right that we also defend to operate by their own religious principles and cannot be forced to violate those principles. And And that's why the distinction between passive hastening of death rather than active measures will take place at a Catholic institution.
Dr. Gillis, how do doctors justify participating in prescribing end-of-life medications if their Hippocratic oath suggests they shall do no harm?
Okay, so one of the things that we talk about, what are the goals of medicine, and what is the scope of practice of physicians? And a lot of times when we talk about medicine as a profession, we look at things like the Hippocratic Oath. And there are many different kinds of oaths. The oaths are generally ethically binding, and they're part of what we call like a social contract with the profession of medicine, but they're not legal. Like sometimes there's like, with professional licensing, they'll have things, but modalities in medicine are the following. What if you talk about what the task or the goals of medicine are, a lot of us think of medicine in a curative modality, that we go to the doctor because we're sick and we want to get better. Or we go and have a surgery to fix our knee. And it is a curative modality, but that's not all that medicine does. Medicine also has a preventative modality where we talk to physicians about preventing us from getting ill. It has a rehabilitative modality to get us, being able to perform treatments for. Those are called palliative treatments. So for example, I have asthma. Asthma cannot be cured. So my asthma is being palliated. And I can live just fine, and thank goodness that it can be controlled, but it's not cured, right? So there are a lot of modalities. So part of the physician's job is not just to cure disease, it's also to ameliorate suffering, right? And that's part of the palliative modality of medicine. So in doing no harm, in relieving suffering, the argument for how physicians as physicians, and it's in every medical oath you want to bring, like there's some oaths do have strictures against causing the death on purpose, right? That because we say do no harm, but we know that sometimes, like surgery, you're cutting into healthy flesh. I mean, that's harming, right? But you're doing it because you're having a curative or a palliative or, another kind of goal. You're trying not to hurt the person, you're trying to relieve suffering, or you're trying to cure or rehabilitate or prevent, right? You're trying to do one of those things, but you're still causing harm as you're doing it. So if the intent of the physician is to ease suffering, then there are many, and then that's part of the goals of medicine. Taking a person's life, like in the Kevorkian case, like then you're going to have issues like with the American Medical Association, for example, that has a prohibition of their members to, for example, be in attendance at capital crimes, like for death sentencing. And they will not, like they'll kick you out of the AMA if you're a physician who attends one of these things. So, because they believe that learning about the death of a person in that situation is completely against the goals of medicine. But it's an open case, like not like some physicians agree, some physicians disagree, but the interpretation of whether or not they can assist in the death of a terminally ill patient at the patient's request is something that's interpretively within the bounds of the scope of medicine. Yes, sir.
I think this is an example where public opinion and our practical experience is far ahead of the policymakers. I don't think the politicians and maybe even the courts have caught up with this. Almost all of us, I bet, have had situations in which we have stood at the bedside of a loved one that was dying. And the issue of Judge Porth's question about doesn't this conflict with the Hippocratic Oath about doing no harm? Boy, I'll tell you that all the years I was in Michigan, that was like the big debate about Dr. Kevorkian, because what does it mean in practicality when you're at the bedside of a person who's in the death throes of life? And what it does sometimes, because practically speaking, for many of us, how many of us have been in a situation in which the best thing that could occur would be a quick death? A quick and dying is part of life. And a quick and a death that avoids needless pain is a blessing.
Can I interject here? There's no anesthesiologist that can't put you out of your pain without killing you if they don't mean to. I mean, sometimes it happens.
And put you into essentially knock you out.
So, but that's it. But you're saying, like, I'm not going to experience the pain if I'm unconscious.
Right.
So let's not. It's not an either or here, right? I mean, we do have amazing drugs and we have amazing clinicians, and so it's something that we call palliative sedation. Right, and so this does happen in some of these cases where a patient is palliatively sedated, which means that they might be in so much pain that they would rather be unconscious because they can't handle it. So we can do that. It's another question of whether or not we ought to just let somebody go. That's a different question, but it's a fact that we can have drugs to get us out of the pain.
Oh, of course. Step one is to alleviate the pain. Of course, step one is to alleviate the pain. But look, the person whose death is occurring has got to be at the central point of making a decision here, rather than have other people make that decision for them.
Okay, Dr. Gillis, is living a life in the sedated state that you were discussing a life worth living?
I think that if we, okay, gonna be a philosopher again. If it's a pain-free state, I would say, I think being in a pain-free state is better than being in a painful state. But I think that we also have to take a couple of steps back. And I think that a lot of times when we have this idea of end of life, and this is something that I when you're talking about things that we could all agree to, like we see the person who is with all the tubes and can't really do anything and has to be attended to all the time and really doesn't know what's going on. And this is a state that could go on for a long time. And it's also, and I'll just say it right now, extremely expensive. Extremely expensive just to have a heartbeat go on and things like that. So one of the things in the debate, I'm a medical educator, I am a philosopher, but I'm not an academic philosopher any longer. I'm a medical educator. So the people that I teach are people who are going to be taking care of patients. And one of the things that, and as an ethicist, I have been a clinical ethics consultant at a hospital, and most of the time when you ask for an ethics consultant, and just so that you know, there are things called ethics consultants at hospitals that help people make decisions that you can call upon at any time.
Do they answer questions?
They help people. Because they help people discover their own. This is our job is to try to get people to make the decisions for themselves. That we don't influence people with their points of view, is to try to get people to make decisions for themselves. So of the things that we try to do is to say, what are the alternatives? Let's talk about some really hard questions. And let's talk about the preferences and the values for the end of life before we even get there, before we get down the road. And what kinds of options do we have before we even get into that bed? And things like, we mentioned the word advanced directives, and we're coming up on National Health Decisions Day, in case you were wondering. And this is a day when we talk about having the conversation, which is a very difficult conversation for people to do. And one of the things, if you look at the studies that people have done, most people do not want to die in the way that we're describing. That is not most people's preference, right? So I would say maybe we should start our education or discussions before we're talking about right to die and what are we going to do with conscientious objection of providers in hospitals and what laws are we going to invoke, because to talk about care of ourselves and our loved ones, I think we should be moving the conversation back and start to talk about some really difficult things on the, the upstream, not the downstream.
Judge, can I suggest
Yes, please.
Perfect. Mac to come up and
Great.
So we were missing our third panelist, and from what I understand, that we just can't get in touch with her, but yet she was supposed to represent ostensibly the opposing viewpoint from Howard here. So my views don't represent Broward College, and I'm just going to play devil's advocate with respect to the this conversation. And if I may pivot back,
Yes, please.
pivot back to the question about how this may impact private businesses.
Yes, please. And religious institutions.
And religious institutions. Howard and I debated this topic with respect to the impending legalization of gay marriages and how gay marriage may affect private business owners such as Hobby Lobby or the cake baker or the flower organizer or whatever, right? And so with respect to this issue, I guess the question is for you, Howard, if the Right to Die movement is going to proliferate in the way that gay marriage has across the country, what impact may that have on private business owners such as Hobby Lobby, who subsidize the insurance for their employers, or rather employees, and say one of the employees or the employee's spouse or whatever wanted to exercise such now the privileged right of active euthanasia on the part of a medical physician? Would Hobby Lobby be compelled to provide money toward a behavior they find objectionable?
Morally objectionable.
Morally objectionable, yeah.
Well, I like giving answers. They may not be right, but at least I'm going to put it out there for a comment. So I'm going to give two different answers to two different parts of your the first part is that I think we have to recognize, like the gay marriage debate that we had when we had it, I think it was before everything. I think it was before the Supreme Court ruled. So it was still, things were still up in the air. Things are still up in the air on this issue as well. We are really in a very evolving situation as people think about this intellectually, legally, and so on. But I do want to say that, so bearing in mind that things are in flux, what your question was, if we took the snapshot now, if there is a right of religious-based private employers not to fund as part of their insurance program and medications that they regard as morally offensive. In the case of Hobby Lobby, it was forms of contraception that were abortificants that they perceived to be abortificants. I mean, it seems to me clear that if that's the state of the law, certainly that they would not be compelled to provide insurance for lethal medication when essentially active hastening of death would be opposed to their religious moral principles. Can I, I'm just going to share on you. Because here's what I'd like to do around. There's a lot of terms being thrown around, suicide and things like that. I'd like to start with maybe what we can agree on. Because there are, as you go bigger into the bigger circles, there's less and less to agree upon. Like, what's the role of the disabled community? What's the role of people who, what happens to the rights of people who effectuated a living will or designated a surrogate, medical surrogate, when they were competent but are no longer competent? There are all sorts of it. But here's the central part. And it's and I call this the central part because it is the subject of the 6 laws in those 6 states and the issue that was before the court, which is really not suicide. I really kind of object to that term because suicide is a situation where there is a life and the issue is, can somebody end life? When we're talking not about suicide, but we're talking about where there is no life anymore. We're talking about the manner in which death is going to occur. How is death going to be prolonged? Will death be prolonged? So the subject of the 6 states, they have their legal structures involve whether or not competent adults, 18 and over, who are within 6 months of death, as certified by 2 different doctors, who ask twice, can take can be prescribed lethal medication that they themselves will take to avoid needless pains and suffering in the end stages of life. I don't think that is suicide. That is a way in which a person is able to control the circumstances of their own death.
Dr. Mack?
So I guess maybe that assumes a few things, right? It assumes that life, as defined by you, largely depends upon one's ability to feel pleasure or pain, right?
I don't know where you got that from.
Well, because
it has nothing to do with me.
No,
I'm
sure.
trying to put the person,
Sure.
that person is the central person.
it came from
I'm
the
not
com-
making I'm not making any valuation of the value of that person's life. That person has the right to make that decision.
It came from the comment, I suppose, that at that stage when one is in such a state of insufferable suffering, you said rhetorically, what life is there then, right? Which then implied that the life is worth living if and only if it's capable of feeling pleasure, right? Or if it's
Well, if I said that, that's not what I meant. What I meant when I said there's no life is just that medically, death is going to be occurring.
Sure.
It's going to be
So I
occurring
guess-
in a week, 2 weeks, in a few days. The question is whether the person will be racked with revulsions in the end stages of this life or die a peaceful death.
Sure. So no one disagrees with the right of everyone to die a peaceful and pain-free death, even the Catholic bishops of the world, right? For which reasons we have the medications that we have. So very often it's possible to die a pain-free death without engaging in active euthanasia, right? Either on the part of the individual, if that individual so chooses, by his or her own capacity, or on the part, or entering in a very tricky situation or discussion with respect to the role of the medical professional in this, given their oath and the responsibility as a medical professional, right?
I don't know what you mean by active euthanasia.
I mean, suicide, but you wanted to redefine the terms, so.
But I don't think that my taking some pills that are on my nightstand in the end stages of my life is active euthanasia. Active euthanasia may have been what Jack Kevorkian did. When euthanasia means somebody does something to somebody else. That's euthanasia. And euthanasia also has within it the connotation that somebody does something to somebody else who hasn't consented to it.
Mm-hmm.
Consent is the key issue here. And not active, but I'm doing it to myself.
Sure.
I am taking lethal medication that I'm administering it to myself. Nobody is injecting me with anything. That's what Dr. Kevorkian did. That is not aid in dying. That's why these terms are really crucial.
They are.
About suicide, euthanasia. Euthanasia has a history of imposing it on certain minority communities. I don't see taking prescribed medication as euthanasia. And I don't think anybody would define it that way.
Dr. Gillis, did you want to weigh in on your definition of euthanasia?
Isn't this when we always talk about the undergraduate student paper that came out that said euthanasia?
We may know some of those students, but not at Broward College.
Not at Broward College.
This
Okay, so here's,
will be the last comment before
okay,
questions.
so here's another thing that I'm going to do, just because I am an academic. And euthanasia comes from the Greek word euthanatos. And eu means good. Like, like eulogy is good words. And so euthanatos is a good death. And so I'll stick with the Greeks.
All right, Nicole, are we opening it up for
Mhm.
questions and answers?
Judge, may I ask you a
Doctor
question?
Armstrong?
So while I love this conversation and the philosophical, ethical, medical, legal, constitutional conversations, I'd love to ask a question of each of you. If you had a loved one on a deathbed today, what would you want to have the right, would you want the right to be able to exercise, asking a doctor to prescribe some form of euthanasia?
So my dad died 3 years ago this past Saturday, and the last 6 months of his life were horrific as a result of receiving a bone marrow transplant to address a rare blood condition. But the 3 weeks prior to his death were even more gruesome, given the kind of condition that he had, and basically his body was just tearing itself apart as a result of the bone marrow transplant, right? So I was faced with that, right, situation. His decision prior to death was that no form of, euthanasia were to occur, right, active, passive, or otherwise, that he would die a pain-free death as possible naturally, right? So there was a point where the doctors asked my mom and I whether or not we wanted to remove the feeding tube to hasten his death, and we said no, respectful to his wishes, right, given his capacity to dictate that prior to his incapacitated state. Now, the reasons for which were largely theological, right? They prescind from his fundamental belief that life is a gift, and it is not something that is subject to our autonomous decision-making, right? So this is where we guess fundamentally disagree, ethically speaking, with respect to the ability to kill oneself, right? That this life that we have is not our own, therefore the ability to take it, either through some prescription dose or otherwise, right, is not something that we are permitted to do. Such was his belief, though, right? Now, the extent to which that should be imposed on everyone else by limiting their ability to avail themselves of such rights, I suppose, is the question here. Now, legally, I wonder where that right is. I don't know, and I guess ethically and culturally, I wonder what country would we become were that to become the norm, apart from the medical issues related to physician responsibility and oaths. But sorry, that was a long answer, but very personal one. So,
I would like to live in a country in which people's wishes are honored and respected. That's what, and I want to say something. I mean, Henry and I have known each other for years, so I hope nothing I say is offensive. But I do want to say that, and I want to live in a country in which my relatives can die in a way of their own choosing, and not forced to die by someone else's theology, which happens to be reflected in the law that denies them the ability to die by their own choosing.
I agree, sure, but I do want to say something positive, is that I don't believe that even many different, I believe that one can be religious and have a close to an absolute value and respect for life without putting every mechanical means at it as well. I think that one can still believe that they're respecting life and refuse care and die without machines. But I lost my father as well, and he went through, again, 6 years of medical care in Canada, which means that my family didn't have to sell their house. But that's
This is not a political
This is not a
conversation.
but he had a wonderful death. He died very quickly of a heart attack in my mother's arms.
Right.
Oh, okay, good. I had a lot of things I wanted to ask, and so I'm going to try to concise it down as I usually do. Right. One of the things I wanted to ask was about Catholic managed hospitals and their right to do do whatever they wanted to do as far as a public or a privately managed hospital. and then I wanted to get into the Terry Schiavo case and about her personal right to end her own life, which she wasn't able to do, but her husband, who was then involved with another woman, decided that he wanted to do. And then I wanted to talk about my father 2 years ago, who passed away from amyloidosis, who was by all means he was trying to fight it. He was trying to fight what he thought was his ailment, but it wasn't his ailment. Ultimately, at the end, he passed away from a heart attack. He did not know what his ailment was until the doctor then told us that he had 3 weeks to live, and then we had no other choice but to just kind of continue on his prognosis until it ended up deteriorating in 2 years ago, 2 years and 8 months, or 2 years and 8 weeks ago. So my question is about the vegetative state. If you are in a vegetative state, let's try to say that really fast. If you are in that state, what then, I guess I present this to the ACLU, what then is the result? Who then decides who ends their life?
Assuming the person didn't have an advance
Assuming the person did not have an advance directive. Assuming that person did not have an advance directive. And assuming that that person was single and they were in the middle age of their lives, who then decides when? Because I guess my ultimate question is, has there ever been, does the ACLU know that has there ever been an instance where someone was in a vegetative state but then reversed their prognosis and then became somewhat responsive, I'm not saying completely, somewhat responsive to some sort of stimulant? Then when do we decide that person is no longer able to make their own decisions? When does that timeline start?
The tone of your question, I want to say, makes it sound like you're asking us if we knew if anybody recovered, because the presumption is that, of course, we would be in favor of essentially pulling the plug on everybody who was in a persistent vegetative state. And I have to say I'm personally offended by the presumption in that question. I mean, that's what the Nazis did. That is what is euthanasia. Euthanasia is where you then essentially kill people who you think have no value to society. Homosexuals, disabled people, people in a persistent vegetative. That is euthanasia. That in America, Judge Wolf is a lawyer. I think that's called murder in the United States. So I do want to say, that Henry had this is the main thing I think that came out of the Terry Schiavo situation. It was a message to everybody: have a living will. And if that person doesn't have a living will, then there's no basis to pull the plug. That would be euthanasia. But I want to say one thing though, because I'm one other thing. A second thing that I found a little offensive, if you don't mind, in your question, because I just can't let the right-wing analysis of the Terry Schiavo case hang out there, which is what you did. You just parroted the notion that what the Schiavo case was really all about was this husband who was involved in somebody else who wanted to get rid of his wife. There was 6 years of litigation before a Baptist Republican judge in Pinellas County that after 6 years of litigation established that her wishes would have been not to be maintained her life artificially in a persistent vegetative state. And he ruled that based on that, he ordered the hydration and nutrition withdrawn. When it was withdrawn, and she died, and there was an autopsy, then notwithstanding all the political rhetoric that you heard from, you remember the U.S. Senator from Kentucky who was a doctor who on television said, oh, she looks good to me. Her eyes were following different stimuli and things like that. The autopsy indicated that she had been brain dead for quite some time. So this notion that, which is what I know very conservative people in Florida like to believe, that what the Shiloh case was all about is how a husband got rid of his wife who was in a persistent vegetative state, really kind of ignores some crucial facts involved in that matter.
But I want to point out to people, just so that you know, when a patient loses decision-making capacity and they're single, there are statutes by law about who makes the next decision, and the states are all different, but they're more like, each of them has their own statute, but they're more or less the same, and it goes down. But it's not just who can make the decision, it's by what standard is the decision made. And the two standards that are usually made are, so you have, if a patient has capacity, the standard is informed consent. If a patient loses capacity but had capacity before and had a living will, advance directive, then that's what you go for, right? If the patient doesn't have one written down, then you go through that statute list and it goes to the spouse. If there's no spouse, so there's a list, right? But the standard by which you make the decision is what's important. And the first standard you go to is something called substituted judgment. And the standard of substituted judgment says, do we have good reason to know what the person would have wanted to do according to their own preferences and values in this particular case? And I've been on hospital ethics committees where we've found people who were homeless and they were in a persistent vegetative state. And we were so concerned to want to know what their wishes were that the caseworker, who's a social worker, was phoning the homeless shelters to see if the fellow had any friends, to see what his decision might have been in this case. So if you go through all of that, you still have no clue about what this human being would have wanted to do in this particular case, then you use a standard that's called the best interest standard. And the best interest standard goes to what would be the best quality of, what would be the best, standard of care in this particular situation. So not what this particular individual would want, but what would the best thing to do be for a human being. And sometimes it is stop the care.
But sometimes it's to maintain.
But sometimes it's not.
Right.
Right? And
Right.
so it's
And that's
really,
where the Terry Shiloh case, where
Yeah.
the dispute was
Yes.
between the family and
Yeah.
the ex-husband.
and exactly, okay. But remember, I'm just saying that there are rules for this, there are state statutes, so that we do have, it's not just anybody and his dog making a decision for a person who isn't married and can't speak for themselves. The other thing is that we're learning a lot about consciousness in states. And now, there's comas and it goes all the way down to brain death, but there's also now a new category called minimally conscious state that we're dealing with. So as we find out more about the brain, we're learning more different things.
Other questions?
Good evening, everybody. My name is Sarah. I work here at Broward College at the student newspaper. My question is, don't you feel that having the right to die will be a way to provide people with the opportunity to die with dignity? Suicide is something that happens every day, whether we want to admit it or not. Don't you feel that having this right, the legal way, or could make it a dignified death? Because at the end, suicide ends up happening. How do you feel about that?
So I guess those that are not in favor of the right to die, so to speak, would not think that having the right is a necessary condition for having a dignified death. Right? You can have a dignified death without having a doctor proactively prescribe medicine for you to take so as to commit suicide, right? I use the word euthanasia, but I know we're disagreeing on the terms there. So,
What do you mean by an example of that, in refusing food or water?
so that case is very much different from one's ability to refuse food and water too. So the right to die movement is less about the patient's right to hasten their death by means of withholding food or water or air, and more about the physician's right or the patient's right by the physician to have that medicine prescribed to him or her. So again, in the case of my dad, he died a very dignified death, without having that means available. The debate is whether or not the means should be available for those that want it, right? And to your point, Sarah, and I'll shut up after this, what I'm interested about, or in rather, is sort of where do these rights come from, right? Where do they originate? Certainly there's no mention of the right to die in the Constitution. We've established precedent through various Supreme Court cases that we can bicker about, which I like to do, perhaps with Attorney Hale here, and he can clarify, that there are these, unenumerated rights now that the court gets to decide whether or not such rights exist as a result of the way that we've interpreted, the 14th Amendment, is it? Right? So how it's possible to have these rights now come about, apart from the legislative process, is something that Howard and I have long bickered about, right?
Well, in some of the states that have it, they did it by initiative by the people. The people created the state constitution.
Sure, I guess so that would be less offensive to me.
Sure.
Yeah.
I guess that
Anyways.
at the end, my question is, don't you feel that people who might not, like for example, people on those states that this is not legal or that is not allowed, don't you feel that they at the end have the choice or the option to end up committing suicide? Because, they can do it anywhere they want and any way they want. So why don't you just allow people to do it, maybe a painless way to say, to phrase it that way?
Do you know much about the history of the Hemlock Society? That was like I remember when I moved to the States, there was something I learned about called the Hemlock Society. And it was a group of people before any of the legalization in the States. And it was like an underground network of senior citizens mostly, who stockpiled drugs, right? And they knew exactly what would kick you down and what wouldn't. And it takes a lot of regular prescription medications of a certain type, and I'm not a physician, and I don't know the types of prescriptions that they were probably, benzos and things like that, or narcotics of some kind. And they would stockpile them so that if people did want to hasten their own deaths, like there was a network where you could get this. But one of the problems was how difficult it was to take all these medications to get the efficacy that you needed. And so I think that this is what you're talking about. This was brought up over and over again to say, my goodness, look what people are going to the extent to do in order to do this, right? And and I don't want to be crude or anything, but I've been at debates before where people just say, well, if you want to go, there's a gun, just go use a gun. And that's just not something that anybody wants to have to do themselves or to leave for somebody that they care about. You know what I mean? Or even for strangers, right? So these are usually the things, I think that's what I was hearing when you were bringing this up.
Thank you for your time.
You want to go over to Mike?
Yeah.
Great discussion. Is there or are there any countries that have a right to die as a national law? And you're shaking your head, Ms. Kelly.
Switzerland is a big country for this, and I have colleagues, I'll be going to an international conference, and Switzerland is actually considering decriminalizing suicide, generally. But they do have it, and this is why there was that fellow with ALS who went, and there was a television thing on that. He was an American who went to Switzerland, and it was for physician assisted, because ALS is that disease that it's a degenerative disease, and that you still are being able to make decisions for yourself, but your body goes, right? So this person wanted to be in the world and enjoy life as long as they could, but it got to a point where they could not do it for themselves, and they didn't want to have their family members be in trouble with any kind of authority, so they went to Switzerland to have this done.
Are there any other countries?
Well, I know that there's pretty open rules or laws in the Netherlands, in Belgium, in Spain. I mean, I'm sorry, I can't, I'm just thinking of colleagues that I'm at this conference with, okay, there's so-and-so of these people, but I know that Switzerland is usually the one that people look at for the most robust rules on this.
But there's a pretty good history of well, Montana is maybe the most recent, but the states on the West Coast, California, Washington, Oregon was the first one. There are now several years, maybe close to 10 years now, of experience, and you could look at the experience of those states. One of the things that's very interesting is that in those states that have legalized, again, I'm not an advocate, I'm not here as an advocate of suicide. I'm here as an advocate for the right of people to end their lives in the end stages of a terminal illness. That's what I'm here for. But one thing I thought that was really interesting about the figures you see in those states that legalize it is that, I don't know numbers, but like in Oregon, I think in 1 year, there might have been 234 people whose doctors prescribed lethal medication, but only 141 died by the medication. Some chose not to. It's kind of like, I forgot the term I'm trying to think of. It's something that is there in case you feel like it's necessary. But not everybody ends up using it.
So people said with that it was about control. Like it was about being able to be confident to go forward with the end stages of one's life because one was in control. And so that they thought, if I can't deal with it, if it's too much for me to bear, I've always got it here. But many of them could bear it.
That's an interesting concept. I appreciate that. Thank you very much.
Could we squeeze in one last question?
Yeah.
The young lady in red? Very good.
Hi, my name is Jonna Emil. I'm a registered nurse, so I have seen a lot of death, uniquely in pediatrics because that is my clinical background. However, I was curious from the panel, because I don't feel like I exactly heard it, but I just wanted to maybe get the insight, your own personal and professional insight on the no's to this conversation that we're having. Because I heard a lot of yeses and maybe why it's a good idea, and maybe not really real answers from a philosopher. But what outside of religious context, what are some things that we are not thinking about that would be the no to this?
Well, like I said, the principal no that we haven't talked about is the concern of the disability community. That's the principal no, and even in states that have legalized and regulated this, there has to be strong regulation to make sure that that people aren't pressured into doing their financial burden on their family. Their disability is such that they're talked into doing it because they don't have a life worth living. I'm trying to put the individual in the center, and the individual's decision to hasten their death or their individual's decision to fight for life, either one. But that has to mean that there's got to be regulations and prohibitions on having this practice for people who are, where it's not voluntary, they're coerced. They're coerced in some way, coerced by family members, coerced for economic reasons, coerced because they have some disability. That's where the big no's come in. The big no's have to come in where where it's not voluntary but coerced.
Any final comments?